I'd be honored to. No, we're so pleased to have Dr. Chowdhary with us today. He comes to us from Tampa General Hospital, where he's the director of translational research in neuro-oncology. And really, he's done a tremendous job at working in this same space at a couple other locations, and he was recruited at Tampa General. And there they have the oncology at the Marcus Neuroscience Institute, and he's the director of the neuro-oncology program. And really his goal is to build a destination world-class site for neuro-oncology, neurology care for the South Florida community. And so he's done a tremendous work already at bringing clinical trials, and we're very excited to have him join us here. So I think with that, I'll turn it over so we can hear his talk.
Thank you, Wendy. Appreciate that very kind introduction. I really enjoyed hearing the morning slides and the morning session, just recapping your program, all the good things all of you are doing. So thank you for that, Wendy. And I'm looking forward to all of us working together. I would presume I should share my screen really quick, and hopefully this is going to work. I know we're in a bit of a time crunch, so I'll try to get us all on schedule. Hope all of you can see my screen.
Yeah, we can see it fine.
Perfect. Well, thank you very much for the very kind invite. And I think I was trying to think about a particular topic, and I know it's more of like a neurosurgical meeting, or at least my impression was it's more of a neurosurgical meeting, and thought about talking about gliomas and the usuals, but I felt that maybe some of the neurosurgical faculty might be interested to hear a bit about the neurological complications of immunotherapies. And there are quite a bit of slides. Maybe the presentation was geared to be more of an hour presentation, but I know I have to conform that into about 25 to 30 minutes. Now, I've spent most of my time in Florida, and started my journey in Tampa, as Wendy mentioned. Went to Orlando for a few, and then I was in South Florida. And now I'm back in Tampa, so full circle. But over in my 20 years, I remember up at when I first basically moved up to Moffitt, there was a lot of work being done in melanoma, and immunotherapies were just coming out. So it's kind of a full circle to that we're doing good things, but sometimes there are complications or risks involved from what we are doing, and it's good for all of us to be aware of some of those complications. Now, I did put a few slides in my talk about some famous quotes that inspire me, and some of you may have seen this quote before: that fate whispers to the warrior, "You will not withstand the storm." The warrior whispers back that I am the storm. And so I believe that all of us are the warriors, and we are there for our patients. And we need to believe in ourselves, because when we wake up in the morning, go to work, things some days are just a little bit better than others, but it should certainly inspire us to keep fighting forward. Although the storm is not a good example, as there's a storm coming to the west coast of Florida. All of you, I'm hoping, are going to be safe. And then also, we should not be afraid of going above and beyond and thinking outside the box, because if we are mostly afraid of making mistakes. But if we don't test the boundaries, and we don't do things above and beyond and go where others have not gone, and overcome the fear of maybe making a mistake, we're not going to discover anything new. So I think immunotherapies kind of embody that, because it was out of the box thinking generated about over maybe 20 years ago. And we've really gained a lot of ground. But today we're going to more focus on some of the aftermath of immunotherapies, and some of the side effects that all of us, when we go to our clinics, mostly in oncology clinics and neuro-oncology clinics, we're always thinking about cancer. We're always thinking about surgical complications, radiotherapy complications, clinical trial drug complications, systemic therapy. But we also have to think about drug side effects and immunotherapy, as you will see over the next several slides, that they do pose very unique complications and side effects that we certainly need to be aware of. So I'm going to try to stratify everything in 4 boxes. We'll talk a little bit about the introduction, and then some of those, pathophysiological items that are ongoing behind the scenes. And hopefully I'll have enough time to systematically go through all the different syndromes. And then more importantly, what are the treatment paradigms? Now, remember when I first moved up to Moffitt back in the early 2000s, melanoma was one of the things that we were working on, and good people like Dr. Jeff Weber and many, many others. And the story of immunotherapy, and I'm going to toggle through some of these slides just to make sure I can conform everything in 25, 30 minutes. But some of the side effects of immunotherapy really started with these anti-CTLA4 or anti-CTLA4 immunotherapy targets, or drugs that were targeting the CTLA4 target. And essentially ipilimumab, which most of you know, still a drug that we use for melanoma and many other tumor histopathologies, was really kind of like the initial drug that we started to notice that, geez, and it's almost like the famous statement that the better an immunotherapy agent works in a patient, the more chance of those immunotherapy-related side effects are. And also then, as we are all moving forward in this immunotherapy phase, you guys also have heard about CAR T therapy and actually bispecific antibodies. And we'll talk a little bit about those as well. Now, I often recommend, and it will be good for all of us to keep a very broad horizon, as immunotherapy or immunotherapy-related side effects may not only affect the CNS, but the peripheral nervous system is also affected, and all the different, stops of that train, like neuropathies, radiculopathies, and muscle toxicity, and then the neuromuscular junction as well. So I would encourage that keep a very broad look at these cases. And the more we know about it, it's like that our mind will see what our eyes will see what our mind knows, that the more we think about it, the more we'll start recognizing. And as Dr. Sherman and other neuro-oncology and neurology colleagues on the call might know this or might experience this on a daily basis, that we probably see 1 or 2 patients every 2 to 3 days that would have gone unrecognized if we didn't pay attention. And also, as we're building CAR T cell programs, and I'm sure there's a lot of good, doctors and scientists that are developing CAR T cell programs at your center, and bispecific antibodies, for instance, that we're only going to see these immunotherapy-related adverse events happen more and more. Now, it's essentially kind of like the analogy that when we're hitting PD-1 and PD-L1 or programmed ligand or programmed cell death pathways, we're basically freeing up the T cells, and we're trying to take advantage of it. And the advantage is that T cells will then freely kill tumor cells, and we will get that anti-tumor activity. But on the other hand, because of its amplification of cytokines and those activated B cells and activated T cells, what we may not realize, that as we're working against these carcinomas, we're also actually cross-reacting normal tissue or normal patient tissue, and hence we're getting some of these side effects. Now, you also want to keep a very broad differential that immunotherapy-related adverse events. I know you and I may only focus on the neurological side effects, but you also may be the first physician or the first healthcare provider that might actually engage these patients. And if they're getting nervous system side effects, they're probably getting other organ system like skin, liver, and GI tract, mostly colon, are the most common, and then especially the hormone function like thyroid gland, pituitary, and you also want to think about other visceral structures like lung, kidney, joints, and muscles as well. So just keep in mind that we as physicians or HCPs might be engaging these patients for the first time. So if you see any, GI side effects or endocrine side effects, you may want to send those patients for a detailed evaluation because you might be their first point of contact. So keep a very diffuse perspective, or keep a very open mind when you see these patients. Now, I think this chart probably puts it all together, and it could almost replace all the previous 5-6 slides. So I tried to stratify this in 3 parts. And basically, when you look at immune checkpoint inhibitors, a term that we've been hearing about for almost 10 years, basically either you have PD-1 targeting or PD-L1 targeting. And if you look at the top left box, you can see that as, essentially as these drugs are targeting PD-1 and PD-L1, they're basically separating that tumor cell's activity to deactivate the T cells. So they actually come out of hiding, or they are now freed up to come out of hiding. And then those activated T cells essentially are causing the anti-tumor effect, whatever the cancer you might be treating. Now, because of that effect, now that's the good side of things, but because of that, those T cells will basically create a lot of autoreactive antibodies. And that's where that cross-reactivity occurs, and then healthy and normal tissue is actually being affected because of that. And essentially, when you look at the clinical manifestations of immune checkpoint inhibiting drugs, particularly, again, like we were chatting earlier, you want to keep a very broad differential. And the more you stratify things, and I teach my students a lot, the more you look at the CNS and the peripheral nervous system, and just go from top to bottom and cover everything. Like in the more distal system, you can see radiculopathies, polyradiculopathies, neuropathies, neuromuscular junction syndromes, myasthenic syndromes, and muscle weakness, myositis, myopathies, etc. But also not to forget about the central nervous system, like hypophysitis is a very common complication. And I'll go down the stream a little bit here, and that's something that can be easily confused with a pituitary metastasis, for instance. So if you keep an eye out, you'll see these things, and aseptic meningitis and different, encephalitic syndromes. Now, we've been talking about immune checkpoint inhibitors for many years, but as I mentioned earlier, as our programs evolve and most of us, larger systems are now developing CAR T cell programs and bispecific antibodies. And I'm sure your malignant heme program and lymphoma program is already using some of these drugs and agents. And bispecific antibodies, which is the middle section, is more these CD3 and CD19 targeting that kind of are much more effective, in which there again the concept is to separate the deactivation of or those activated or deactivation of our normal immune system, and freeing up those T cells. But it just leads to a very supraphysiological expression of inflammatory cytokines. And then hence it leads to the famed syndrome of the cytokine release syndrome, which are very diffuse systemic symptoms of fever, tachycardia, hypotension, and hypoxia. And then encephalopathy can occur, as well as all the different syndromes. Seizures can be common, altered sensorium. And some of the bispecific antibodies, actually, the risk of causing this CRS or this cytokine release syndrome is fairly high. And a few slides down the road, I'll talk a little bit more about that. And also, as I mentioned before, CAR T cell therapy or chimeric antigen receptor T cell therapy. And what's kind of interesting about CAR T, which is distinct from bispecific antibodies and immune checkpoint inhibitors, that CAR T cell therapy, the same strategy, it's almost like a very directed T cell that's infused back into patients to kill their particular lymphoma or whatever disorder we're trying to treat CAR T cell therapy for. But it causes a very unique syndrome of a blood-brain barrier disruption, and this causes extravasation of immune cells and cytokines, and hence the famed immune effector cell-associated neurological syndrome. And the incidence of this ICANS is actually fairly high, and again leads to a confusion, disorientation, and seizures. And I'll talk a little bit more about that downstream as well. So we're going to quickly run through a few slides, and forgive me for not being able to spend as much time as I would like to on every slide, just to kind of conform everything within the time allotted. Now, when you look at the PNS system, again, want all of us to think very broad, that you can get anywhere from radiculopathy or mononeuropathy, radiculopathy, neuropathies, and most of the clinical features. And generally, depending on the patient, of course, it is individualized, but generally after 2 to 4 cycles of an immunotherapy agent, that's where most medical oncologists will follow up with their patients and ask them about neurological side effects, or that should be the proper way to proceed. Now, neurologists and neuro-oncologists, we may not get involved with these patients until our medical oncology colleague may call us and say, hey, geez, I think this might be a sensory neuropathy from immunotherapy. But you can see almost everything: sensory deficits, motor deficits, loss of reflexes, and then cranial nerves can be involved as well. Now, the overall incidence is still small; it's about 1.3%. And then that classic Guillain-Barré type syndrome, or the mimicker of a Guillain-Barré type syndrome caused by immunotherapy, is much less, or there's a much smaller chance, about 0.1 to 0.2%. Now, you also want to think about other items or common things still happen commonly. Our cancer patients are prone to getting Guillain-Barré type syndromes, and which can be post-infectious, and paraneoplastic syndromes can also occur. They may have an ongoing separate parallel scenario of CIDP, or chronic inflammatory demyelinating polyneuropathies. You could get a neuropathy from chemotherapies and other systemic therapies that the patient might have been exposed before. So it's not as simple as someone has had an immunotherapy drug and that is most likely immunotherapy related. Now, when you see such a patient, you probably, as all of you might imagine, you want to go through some of the usual, electrophysiological workup. And again, you may have heard this in rounds in clinics, that many of these immune-mediated neurological syndromes can have a Guillain-Barré type scenario. Now, you may recall from your days in training that when you look at these Guillain-Barré type syndrome, there's a classic albuminocytological dissociation, which basically means that in Guillain-Barré type syndrome, that CSF protein is high, but CSF pleocytosis is not present. So we term it as this albuminocytological dissociation. But what's kind of interesting, in immune checkpoint inhibiting drug related Guillain-Barré type syndrome, you may not see that classic albuminocytological event. And but still, if someone presents in such a way, CSF sampling would become important. Now, another deceiving item I wanted to highlight, that one of the items that you can see often with immunotherapy related, and I've seen this a few times, that when patients present with those radiculopathies, and if you get an MRI with contrast, you can actually see enhancement of the cauda equina and the nerve roots, just like in Guillain-Barré type syndrome. But reportedly, it's more enhancement, and there's a higher chance of immunotherapy-related radiculopathy causing enhancement. So you can obviously see such enhancement. And one of the items you're going to worry about, could this be CSF disease from patients' primary carcinoma? But then again, if you've done CSF sampling, most likely you're going to send it off for cytology. And if that's negative and it fits the picture, then you can easily make that good conclusion that it's probably immunotherapy related. Now, if you follow up these patients, which I would recommend you should, and you do a follow-up scan or a follow-up study, usually this enhancement in about 2 or 3 months should improve and should get better. Probably one of the most feared complications of immunotherapy is these neuromuscular junction disorders. Again, it's hyperactivity of the T cells and the B cells and the cross-reactivity of normal tissue. But what's kind of unique about immunotherapy-related neuromuscular junction disorders or myasthenia-type syndromes, that is mostly bulbar, and there's less of a generalized effect, although it can happen. But many patients will have an ocular myasthenia or bilateral ptosis diplopia, although I'm sure some of you who see these patients have seen a generalized myasthenia presentation as well, which the usual way, generalized weakness, dysphagia, dyspnea, and you can get myocarditis and myositis. So the classic triple M syndrome of myasthenia, myositis, and myocarditis. You may have heard about that term, that triple M syndrome. So myasthenia is part of that triple M syndrome. The overall incidence is still small, about 0.12% to 1.16%. And of course, a differential would be, could it be a paraneoplastic syndrome presenting as a neuromuscular junction disorder? So again, keep your differential very broad, and but with a good comprehensive workup, like acetylcholine antibodies are also present. About 60% of the patients, that might confuse, but a patient with a classic, myasthenia gravis, the chance of the antibody finding is just a little bit higher. Now, the treatment can be very similar, of course, apart from discontinuing the immunotherapy. Acetylcholine esterase inhibitors can be used. Steroids are kind of it's been reported, and this has been published over the past few years, that sometimes with immunotherapy-related neuromuscular junction disorders, when you initially pulse them with steroids, you might see a decline. But eventually, as the steroids do what they're supposed to do, patients do improve. And Plex and plasmapheresis could also be an option, although colleagues around the country have used Plex first, or just stopping immunotherapy and not trying steroids because of that potential risk of decline. You can also get muscle pathology and classic, and sometimes it's a mixture of radiculopathies and neuropathies and muscle weakness. And basically, it's because of the autoimmune reaction. You can get anything from limb weakness to a necrotizing autoimmune myositis. You can see dermatomyositis and polymyositis type scenario, and then of course the cardiac muscle weakness as well. Still less chance, less than 1.67%, and the differential would include dermatomyositis and polymyositis. And I'm going to, again, for the sake of time, toggle through some of these slides a little bit quickly. I apologize for that. But as you would imagine, in these myositis type scenarios or muscle pathology, you'll see elevated enzymes, and at times, rarely a muscle biopsy would be needed, and you'll see a lymphocytic infiltration. EMG can be done. I always recommend, when there's myopathy, to get a cardiac evaluation, because that incidence of triple M syndrome gets higher. So if you pick up a patient with a neuromuscular junction disorder as myasthenia, you probably want to look for myositis and cardiac side effects as well. The autoantibody chance or finding is a little bit low, and treatment is usually steroids. Now, talk a little bit about what I mentioned before about hypophysitis. Actually, It's a bit more common than you might imagine, and I probably see about 1 or 2 cases per year. And it's generally patient will mention, geez, I started immunotherapy or CAR T cell therapy, and I'm just overall just weak and getting headaches and very tired. And some of these patients might be getting steroids for other reasons, and you want to look at it all in like one box and evaluate the patient at length. And but one of the best ways to detect hypophysitis would be to do just the usual MR based testing with contrast. And when you look at the sagittal views here, T1 acts, that pituitary seems enhanced. You can clearly see it's not that enlarged, but it definitely looks abnormal. And one of the first things you might think about is a pituitary adenoma. Maybe it's a pituitary met, because pituitary mets do occur, or it could be some other pathology. And because we don't see it as often, or we may not recognize it, but that's how hypophysitis can be very deceiving. And with a good eye and looking out for these items, that you might be able to pick up these cases, and usually discontinuing the immunotherapy and basically some endocrine management, hormone replacement therapy. Many of these patients will recover, although there's good data that some patients may long-term lose their pituitary function. Although it's been reported that even up to a year or two later, patients may rejuvenate or recover their pituitary dysfunction. Now, another underreported side effect of immunotherapies, not only CAR T cell therapy and bispecifics, but with immune checkpoint inhibiting drugs, that you can get almost like an encephalitis, an aseptic meningitis. And it's just that classic picture of neck stiffness and headaches. Incidence is still low, and you want to look out for other things like viral meningitis, leptomeningeal disease, bacterial meningitis. Workup is, as you would imagine, CSF analysis. And I'll show you the MRI in just 1 second, but the common treatment, apart from discontinuing the immunotherapy drug, would be IVIG, Plex, and steroids. So when you look at the MRI for these patients who are developing inflammation or autoimmune reaction, usually you'll see T2 and flare abnormality. And there's also data with using RTX or anti-CD20 drugs, and rituximab can actually help. And when you look at the MRI, there's those classic T2 and flare changes that could mean anything, but they are actually reversible. So again, discontinuation of the immunotherapy, as some of these patients may, as you would imagine, get admitted to the hospital, initiated on IV steroids and IVIG if needed. And then as you image them and follow them downstream, these T2 flare changes will actually improve and will be able to recover. So I know we only have a few more minutes left, but this talk would not be complete without talking a little bit about this famed cytokine release syndrome. And some of you who spend enough time with the oncology group and the lymphoma group and the CNS lymphoma groups, and the drugs that we use, that you may have come across patients with this. So, cytokine release syndrome, again, as we were chatting earlier, it's basically all those excessive, auto-reacting cytokines, or that supraphysiological range of those cytokines being released, and just leads to a very encephalopathic picture. Patients have a very diffuse symptoms with feeling dizzy, confusion, headaches, and hypotension as well. Now, with certain drugs like blinatumomab, it's as high as 11 to 14%. But even if you look at CAR T cell therapy or chimeric antigen receptor T cell therapy, that some may argue that almost 100% of these patients will get this cytokine release type syndrome. And hence, if you have a CAR T cell program, which I would imagine you do, some of these patients were expecting them to go into CRS, and they're admitted to the hospital to get through a few days of this cytokine release syndrome, and so they can be treated accordingly. Now, there are two drugs, actually, tocilizumab, which is an anti-IL-6R receptor antagonist, and cetuximab, or anti-IL-6 targeting, and a few other drugs which can be given as an inpatient, and it can help with that cytokine release syndrome. So if there's a couple of things I would like all of you to take away from this talk, not to forget the CRS, as is something that if you spend enough time in oncology, especially with malignant heme and lymphoma patients, you're going to see this, and it is luckily, reversible. Now, apart from CRS, another item that I would like all of you to take home is this immune effector cell-associated neurological syndrome, which is almost another classic scenario of chimeric antigen receptor T-cell therapy. And as T-cell therapy, CAR T-cell therapy programs are growing in all good cancer programs, and more patients are being treated, we're going to see this a lot more. And again, very diffuse symptoms, encephalopathy, hallucinations, cerebral edema. As you might remember, I spoke a bit earlier about that CAR T-cell therapy causes extravasation or breakdown of that blood-brain barrier. So because of that, cerebral edema and seizures are very common. And 21% to 64% patients can get ICANS. So that's a pretty high incidence of it occurring. You'll do the usuals, EEGs, and do an MRI. And one of the best ways to treat ICANS is supportive care and steroids. They have seizures, you can put them on anti-seizure drugs, but thankfully so, it's only a temporary reason. Within about 4 to 6 months, you can discontinue. And then again, one of the biggest challenges that I think we face with these immunotherapy-related adverse events, that is kind of like a paradox, that patients that are going to respond to the immunotherapy drug are the ones that are a higher chance of getting side effects. So you're in that, conundrum, if you will, that what do we do next? So usually it's a team approach, and you approach it, and sometimes you can reduce the dose of the immunotherapy. Sometimes there's an alternative therapeutic strategy, and so you still get a chance to get the patient on some effective therapy. So that it was kind of like a crash course through immunotherapy-related side effects. And any good meeting, like the SNO meeting or ASCO, there's several talks every year. So I apologize to make all of you go through this, textbook, if you will. But I think you will emerge from this talk and lecture feeling a little bit more intelligent and well poised and comfortable going to your clinics today. And you might see a patient today. And I'll leave you with a couple of more quotes. I'm originally Canadian from Western Canada, so I had to show some mountains and how things would look out there in a few months. And Alexander the Great said, "There's nothing impossible for those that will try." And as Walt Disney said, that quit talking, let's begin working. And of course, Steve Jobs, that we need to, that it's those people that think outside the box, which is all of us, are the ones that will really make a difference. So thank you so much. It's 7:57. I know I was destined to stop at 7:50, but I'll stop there, leave a few minutes for questions. Thank you very much. It's either perfectly understood or nothing was understood.
I'll just go ahead and jump in. Thank you for that excellent talk. Seriously, I think it's interesting, as you and I know, we were practicing at the time these immunotherapies, came into use, and we were seeing neurologic complications. And initially, we had to make the ties. And like you said, especially now with CAR T-cell therapies and some of our trials too that are combining immunotherapies, we're still learning about the neurologic complications, like when you do the checkpoint inhibition with the vaccine therapy or what have you, that we're seeing that continue to increase. And so I think part of our job, like you mentioned, is to get the word out so that people are recognizing these complications and that are addressing them. Especially, I appreciate highlighting, the hypophysitis, because again, it can get confused for pituitary mets, which we see, not infrequently. So I appreciate. I think that's a great crash course, as you say, especially for the neurosurgical office here, or audience here. So thank you very much for your talk.
Thank you, Wendy, and thank you all for having me. And be more than happy to come back some other time if invited and talk about some other topics. And looking forward to working together. Appreciate the patience. Thank you. I guess I would stop sharing.